Hi, everyone. Welcome to week 5. This is bipolar disorders, i.e., mood disorders. Mood disorders is a general category for depressive disorders and bipolar disorders, but the word is meant to specify bipolar disorders. Especially when we talk about medication and we talk about mood stabilizers, I've just found that it's easier to remember mood stabilizers as far as the shift in polarities versus depressive disorders, looking at a single polarity. So I hope that makes sense. I will use them interchangeably, but this is what we're going to talk about are bipolar disorders under the general category of mood. In our lineup, in this lecture, we will be talking about bipolar 1 disorder, i.e. mania, bipolar 2 disorder, i.e. hypomania, cyclothymic disorder, and bipolar specifiers of episodes with mixed features as well as rapid cycling. Okay, so I'm going to stay here just for a moment. I'm setting this up. You can go back to this, but I'm setting this up as to just help you understand how things can get a little crazy when it comes to our conceptualization of verbiage. All right, so remember last week, we talked about the difference between major depressive episodes and major depressive disorders, how those can be used interchangeably for one direction, but in the presence of a diagnosis of major depressive disorder, we need to have a major depressive episode, that the major depressive episode is also used to be able to identify a person's experience in a depressive period of time, right? Now, similar aspects go for understanding bipolar disorder criteria, okay? So we have two options. When we're talking about bipolar disorder, we either have bipolar 1 disorder or bipolar 2 disorder. Now, if we have bipolar 1 disorder, what this often means is that we have someone who is experiencing dual polarities of manic episodes and major depressive episodes. For the trickiness of this diagnosis, we don't actually need to have somebody that has experienced a major depressive episode, however. It just often happens that way. And for the conceptualization of bipolar disorder, a lot of people that have bipolar disorder often start with major depressive episodes. And so what was once a major depressive disorder, depending on the stressors, depending on a biopsychosocial perspective of what essentially enhances or uh, can predisposition a person to get into a higher degree of a mood episode. That's where it can go from a person having major depressive episodes into experiencing a manic episode. Then that's where the definition or the diagnosis shifts from they used to have major depressive disorder, but they now have bipolar 1 disorder. I'm going to give you visuals too, so just stay with me, okay? Now, for bipolar 2 disorder, this is where we actually need to have major depressive episodes to be included in the disorder. But we cannot have any experience of a manic episode. This is when you think of bipolar 2, think of hypomanic episode, okay? So this often can still arise from a person having experienced major depressive episodes, which would have been diagnosed as major depressive disorder. Then something triggers a person shift into a different polarity and they have hypomanic episodes. We cannot see manic episodes in this disorder. Okay. So I'm going to leave that here. This is on the bottom part of this. This is a breakdown of, this is kind of like a decision tree. Um, oh, yeah, I'll just go over this really quick. If there's a presence or history of depressive episodes, but no history of manic or hypomanic episodes, a person stays in major depressive disorder. Again, once they cross the threshold and there is a presence of a manic episode, ding, 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 they have bipolar 1 disorder. Okay. Um, Even if they've had past hypomanic episodes, the highest peak becomes the disorder. And I'll speak to that again in a visual. But if they never have manic episodes and just hypomanic episodes, then, oh, go away, taskbar. Then that peak becomes bipolar 2 disorder. Oh, went away. Okay, to further build this out, I'm going to go into bipolar 1 disorder. So, again, this is manic episodes. Now, what we have to see is that there's a distinct period of abnormally and persistent elevated, expansive, or irritable mood and abnormally and persistently increased activity or energy. Again, I'm going to break this down. Um, Lasting at least 1 week and present most of the day, nearly every day, or any duration before that if hospitalization is necessary. What this means is that we have to see a distinct period of elevated mood, of increased activity or energy that lasts at least 1 week, or if sooner, um, or if severe enough that a person needs to go into hospitalization, right? So whichever comes first, 1 week or hospitalization. If their symptoms kick up and within 3 days they needed to go into the hospital because it's that severe, that indicates the criteria for medical necessity has been met, and we would still count that as a manic episode. I might be giving you too much information, but I hope this makes sense. Okay, so during this period of mood disturbance, of um, elevated or irritable mood plus heightened activity level, what we need to see at least three symptoms. um, 4, if the mood is not elevated or expansive, but just irritable, we need to see these symptoms to meet criteria. So, inflated self esteem or grandiosity, decreased need for sleep. So, this is where a person does not feel tired, they do not feel sleepy, i.e., sometimes they don't get any sleep or they feel very rested after just a few hours of sleep. To me, when I assess for bipolar 1 or 2 disorder, I always ask about sleep because that's usually the first thing that we start to see shift as far as a person's baseline. That really indicates heightened energy levels. And sorry, my cat's trying to get on my computer. We also see a person that's much more talkative than usual or pressure to keep talking. That's going back to the mental status exam, pressured speech. And I love how the DSM broke this down and how that really aligns with the mental status exam, because often the common term is pressured speech, but the pressure to keep talking. And to me, I always imagine somebody like pushing the speech or pushing the words out of a person's mouth where they just keep going and going and going and going and going. And it's just this like really strong force of words that are coming out very quickly. Now, this connects to the energy conceptualization. And what this also connects to is the next criterion, which is flight of ideas or a subjective experience that thoughts are racing. And so these can all really happen in a cluster of like a person feels much smarter. They feel like they have this creative surge of an experience. And so as a result of that, they're just constantly like working on this thing, or they're thinking about this, or they have all these ideas of the special project that they want to work on, and they're going to stay up late to work on this, and let me tell you all about it, and let me tell you about where this comes from. And no, I don't need to sleep. I don't need to sleep at all, because if I sleep, then I'm going to slow down and my brain is just going way too fast. That's what that feels like clinically, okay? That being said, if a person's experience is this, they're gonna have difficulty being linear in terms of their thought process. So they're gonna get distracted at a much greater level. So we're gonna see that their attention is too easily drawn to unimportant or irrelevant external stimuli. Um, Perhaps on the other end of the spectrum, there's an increase in goal-directed activity. So they are really, again, focused on a particular task. They have this like heightened attention level of needing to focus on talking to people, working on something that's, again, a special project, whether this is work, school, or even just sexually. So there's this really, it's almost like the attention that we see with somebody who has ADHD. When they're hyper focused, we can also see this happen when somebody is using a stimulant. And so this is a stimulated response that is coming out in this presentation. I hope that makes sense. Now, what we also really see is excessive involvement in activities that have a high potential for painful consequences. And so this is when people are engaging in buying sprees and sexual indiscretions, foolish business investments. This is like the impulsivity at a really high level. So, this is, commonly when people are in a manic episode, what they can do is almost like black out because the energy level is so high and they are doing things very impulsively. This is where people just decide on a whim to go to Vegas and spend a bunch of money because they're on top of the world. They're not thinking of consequences. They pick up somebody and sleep with them. They have multiple sexual encounters during this period of time. I have talked to one of my patients at a previous treatment center, and I saw them after they got out of the hospital because they were hospitalized from a manic episode. And what they said was, "Oh my gosh, Lindsay, I can't believe this. Like, I smoked a little bit of used a little bit of meth, and I was just off to the races. And basically, I spent $17,000 in 3 days." And they felt terrible, they felt awful, they were so remorseful. It was like they were a completely different person, but while they were in that manic episode, they couldn't be touched. They had all the money in the world. "Don't worry, I'll get it back," or "This doesn't matter because I'm perpetually rich and I have this idea that's gonna make me a bunch of money." The grandiosity, this is what I really appreciate about this conceptualization, is the grandiosity, the increased energy, the distractibility, the increase in goal directed activity, the excessive involvement in activities. All of that is so heightened. This is where, when we think heightened, we think about this peak of um, a peak of what a manic episode looks like, especially on a graph. Okay, so I'm going to get to that too. So I hope that that makes sense. I know that was uh, a little bit not fragmented, but tangential and circumstantial as far as how I explain this. Okay, I'm going to get back to the disorder criteria. So I'm looking at C now. Now, all of that to be said, this is sufficiently severe to cause marked impairment in functioning, right? Not just in one area. This would be multiple areas of life where a person, we this stands out very much. Somebody cannot hide that they are in a manic episode. This does not fly under the radar. So this is very much where we would see it cause impairment in a person's life, not distress necessarily, but impairment. And again, this is where we go back to the need to be hospitalized to prevent harm to self or others. I've heard of the conceptualization that families supporting loved ones with bipolar disorder have, which is they'll continue to go until they run out of resources, which was like the most clear to me when conceptualizing this. Because a lot of students ask me, well, how long can a person go with bipolar disorder? You say that it can, at least be once a week. But if it goes untreated, if the person doesn't get hospitalized, how does that continue? And I think that the conceptualization is they go until they run out of resources is very accurate, because that's where it ends up, where a family is like, "Hey, we have to take you into the hospital because this is just so extreme as far as behavior." Where there might be a person is really putting themselves in such excessively risky situations that there's a danger to themselves or others, but usually there's some higher level of intervention that happens that causes a person to have to seek treatment. This is most of the time. Okay, so let's just think about it that way to help you conceptualize what type of ceiling happens and how. Now, we would identify, as we are continuously practicing doing, that we have to rule out that this is not caused by a person being on a stimulant, a person being taking some sort of medication or having some sort of medical condition that is going to cause these symptoms. But a caveat to that is, let's just say, again, and we've talked about um, this transition from that some people have from major depressive disorder to something actually triggering a manic episode. What we know is that if a person is misdiagnosed and they have major depressive disorder that sneakily turns into a bipolar disorder, a catalyst to that can be antidepressant medication. And so I will talk about this a little bit more, but in the later on in the presentation. But what we know is that antidepressants can kick up mania, and we see this on the opposite polarity too, that if a person is incorrectly diagnosed with bipolar disorder and they're given a mood stabilizer, then that will shift them into a depressive episode. So again, I will talk about this toward the end of the presentation, but sometimes this happens without the you might be being like, well, wait, why would a psychiatrist give somebody the wrong medication? Sometimes the medication is the catalyst to that emergence of mania. It's awful. It happens, not with everybody, but it does happen with a notable percentage of people. And this is how we learn that somebody actually has bipolar disorder. Does that mean that we can prevent it? Not necessarily. Does that mean that there are risks to taking medication? Yes, of course. But this is where we go back to the idea that if a person's depressive disorder, major depressive disorder, is so severe that it really does warrant medication, for the most part, most people that have major depressive disorder that take antidepressants continue to have major depressive disorder. It really is just for a percentage of those that have undiagnosed bipolar disorder that this will happen. If you have questions about this, do not hesitate to ask me when we talk about it in class. But that's what the note in this diagnosis means. So criteria A through D constitute a manic episode. We have to see again at least one lifetime manic episode for this diagnosis. Um, what we know is that we cannot have any symptoms of schizoaffective disorder. We'll talk about that next week. That a manic episode cannot be superimposed on schizophrenia. Basically, we have to rule out any sort of schizophrenia spectrum disorders, because that's where the reason I have all of these weeks stacked the way that they are is because we build the foundation for major depressive disorder. Then that can shift into bipolar disorder. And then you'll see next week that schizophrenia spectrum disorders can encompass mood disorders too. And so this is where we need to be diligent about ruling out um, the major depressive episodes belonging to major depressive disorder only, and we need to rule out the other side of that, which is the schizophrenia spectrum disorders. Okay, are you still with me? I hope so. Now, here's a mnemonic for you, which is dig fast. And so you can remember it this way or remember the criteria through just studying the actual shot of the DSM. So, but dig fast is distractibility, involvement in activities that have a high potential for painful consequences, grandiosity, flight of ideas, increase in goal directed activity, decreased need for sleep, and talkative, i.e., pressured speech. Okay. So we see the screenshot of John, who we are going to watch in class, who has a really important cure for cancer, and he needs the doctor to focus on that with him. And so you'll see what that looks like as we watch it in class. Okay, so that's a way to be able to remember mania. Now, here's what I again appreciate about the structure of the DSM of mania versus depression. Okay, so I just made this. I hope you like it. It's how's Kitty's vibe. All right. So the two components that are the most important for us to look at are mood and energy, right? So we see on one end of the spectrum, increased in elevated mood and increased activity or energy. Okay. Irritability can belong to either one. We can see irritability in mania or hypomania, or we can see irritability in depressive episodes or major depressive disorder. But on the other end of the spectrum, we see a depressed mood, right? A decreased mood and a diminished interest a diminished interest in interest or pleasure, i.e. anhedonia, and fatigue or loss of energy. So that is where we see. And on the other end of the spectrum, this is where we see decreased mood, right? Depressed mood for most of the day, diminished interest or pleasure in all or almost all activities, right? I know I'm grasping a little bit with activities versus activity or energy, but just stay with me. But what we see is the fatigue or loss of energy. And this is one of the diagnostic criterion. It's not necessary, but we very much see it commonly in those that are suffering from major depressive episodes. Okay, so just think about that. That on one of the end of the spectrum, we're going to see the elevated mood and the increase in activity, and on the on the other end of the spectrum, we're going to see that decreased mood and energy. Okay, so just check the vibe. Is it high, high or low, low? And where does irritability show up? But what does that mean as it relates to elements of energy? Okay, so that's one visual for you. Now, let's pause and reflect. Okay, I gave you a lot of information. We're going to do this in bite sized pieces. Now, what is the necessary symptom for a diagnosis of bipolar disorder? Again, when you think about just the things that are fundamental, like just even going back to this, right? What do we absolutely need to see in order to have a diagnosis of bipolar 1 disorder? We need to see that persistently expansive, elevated, or irritable mood, and we will see increased energy level, but regardless, but the focus is first on the mood. Okay, so we have to see persistently expansive, elevated, or irritable mood first and foremost. Now, how many other diagnostic symptoms are required to meet the criteria for the diagnosis of bipolar 1 disorder? If you can remember that. So we have to see some sort of expansive or irritable mood. If we see expansive or elevated mood, we just need 3 additional diagnostic symptoms in the form of increased energy, right? So that's where we go back to the distractibility, the flight of ideas, decreased need for sleep, grandiosity, talkativeness, any of those, we need 3. If the mood is solely irritable, we need 4 additional symptoms. Now, you may not diagnose, if we're just talking about irritable mood, that may not be your first marker for somebody being in a manic episode. That's probably where you're going to see the other energy related things come up, but a person is not like feeling on top of the world. They're just really, really irritable. This is where it can kind of fly under the radar, but you still have the flight of ideas, the decreased need for sleep, the talkativeness, the involvement in activities with high risk, the distractibility. That's where we need 4 of those symptoms in order to facilitate the diagnosis of bipolar 1 disorder. Now, does the person need to have met criteria for a major depressive episode in order to meet criteria for that's supposed to be bipolar, let's say bipolar 1. I need to fix that. Do they need to have demonstrated a major depressive episode? No, right? A previous major depressive episode is not necessary, but we will often see it within the scope of the diagnosis within the scope of the diagnostic presentation. Now, how long must manic symptoms persist in order to meet criteria for the diagnosis? Remember, that's 1 week or more, or if the person's symptoms are severe enough to warrant hospitalization, right? So at least 1 week, or at least 1 week, or hospitalization, whichever comes first. Sure that yep, at least 1 week. Okay. I just was checking my wording. Sometimes it's at least 1 week or 1 week or more. Just think 1 week. Okay. um, Now we're going to shift to hypomanic episodes, so bipolar 2 disorder. So this is where we see a distinct period. Again, look at the structure as far as hypomanic episode and manic episode. The wording is the same, right? Abnormally and persistent elevated, expansive, or irritable mood, and abnormally and persistently increased an activity or energy level. The difference is that we see this lasting for at least 4 consecutive days, okay? Present for most of the day, nearly every day. Symptoms, again, are the same. Associated symptoms with this are the same, and the same structure as it relates to time. 3 or more of the following symptoms with the elevated or expansive mood. 4 if the mood is only irritable. But we're going to see again the grandiosity, decreased need for sleep, more talkative than usual, again, pressured speech, flight of ideas, thoughts are racing, distractibility, increase in goal directed activity, and excessive involvement in risky behaviors. What we also know, because this is where hypomania gets a little bit tricky conceptually, these this is not just a person having a good day, okay? It's not just a person like getting a promotion and they're on top of the world. They had a really strong cup of coffee. They feel like they need to just go on a shopping spree because they haven't treated themselves in a while. That's not what we see. We have to know that this is actually a change in a person's functioning, um, a change in a person's functioning from baseline when they're not symptomatic, and it's still observable by others. But this is where it gets tricky. This behavior can fly under the radar as far as distress and impairment. This may not be severe enough to warrant hospitalization. It may not be severe enough to actually cause an impact to work, to relationships, to school, etc. If we look at a hypomanic episode alone, that's where before in the DSM-4T, well, DSM-4 and 4TR, hypomanic episodes or bipolar 2 were generally thought of as not severe. Like this was the lesser severe of the diagnoses. This was like not as big of a deal, especially in comparison to bipolar 1 that shifted. This is where it gets tricky, okay? So I want you to think about the difference between impairment in a hypomanic episode versus impairment in the overall presentation of bipolar 2 disorder, okay? So when a person is in a hypomanic episode, these behaviors, although they are the same in manic episodes, on paper, the behaviors are not actually severe enough to cause marked impairment in terms of one's functioning. Okay. So people can have a decreased need for sleep, for example, but they may not be sleeping as infrequently as somebody that has bipolar 1 or is in a manic episode. So think about these being present but less severe. Also, what we know is that when people are experiencing these symptoms, they feel good. So we're not going to see any sort of distress. But what we know is that while they're engaging in this heightened type of mood disturbance, it's not severe enough to actually cause an issue that should necessitate hospitalization or cause a person to extremely wear out their resources. Okay. So I'm going to get to the bipolar 2 criteria in a second, but just stay with me on this concept of a hypomanic episode. Now, the same goes for ruling out physiological effects of a substance, of a medication, or another medical condition. Again, a person can be on meth. And this is very much what we can see in terms of hypomania, or again, going back to mania. Um, we also know that medication can do the same thing as far as shift a person from being in a state of a depressive episode to them putting them in a state of a hypomanic episode. We can also see in this note that we can have hypomanic episodes under the umbrella of bipolar 1 disorder, but it's not required. We can just see that if you were to chart out somebody's overall mood related experience, that if they've already met criteria for mania, again, they've met criteria for bipolar 1 disorder, but we can see either pre-existing hypomanic episodes or subsequent hypomanic episodes that still falls under the umbrella of bipolar 1 disorder. Okay. So we're just going to rule out mania when we think about bipolar 1, right? I know I'm repeating this at this point. Now, here's a shift. I hope I'm clarifying this without making it more complicated. Okay, before in the DSM, there was a fundamental difference in terms of bipolar 1 disorder and bipolar 2 disorder, where in the DSM 4, we used to think about bipolar 2 disorder as like a baby disorder, like a lesser disorder, like, oh, you only have bipolar 2 disorder. That's not that big of a deal. Because what that conceptualization was based off of was a hypomanic episode. Now, in the DSM 5, that's changed, where this is where we need that combination of hypomania and a major depressive episode in order to meet criteria for bipolar 1 disorder. What do we know about major depressive episodes? What do we know about the concept of major depressive disorders? How does that relate to distress and impairment? We know that major depressive episodes cause distress and impairment. And so what the revisions from the DSM-4 to the DSM-5 entailed was conceptualizing, hey, bipolar 1 is just as serious as bipolar 2, or let me invert that. Bipolar 2 is just as serious as bipolar 1. What makes it serious is the degree of distress and impairment caused by the major depressive episodes, caused by the depressive component to that. And we can say that for bipolar 1 and bipolar 2, people, especially after engaging in behaviors that while they're under the influence of their manic or hypomanic episode, that can be so severe. The consequences of that can be so severe once they come out of that, that a person feels increasingly more depressed as a result of the shame and the guilt from knowing what they did while they were under the influence of that disorder. I've never said that before, under the influence, but I'm going to actually use it because it makes the most sense. So, what I'm trying to say here is that when we conceptualize somebody being in a hypomanic episode, they might report that they're fine and nothing really changes for them in their lives while they are in that hypomanic episode. But when we zoom out, we identify that they've never met criteria for a manic episode, and we do see a demonstration of major depressive episodes. We know that that together is going to be severe enough for a person's overall impairment in their functioning. And I would say too that when a person, I've never had bipolar disorder, but when a person has that shift in polarities, that shift alone can be distressing because they're having difficulties in either end of their lives, even if it's not causing distress or markedly severe impairment while they're in that hypomanic episode. It's the overall experience that can be difficult for them. I will build this out in cyclothymic disorder too. So, are you with me? I hope so. When we look at the criterion for bipolar 2 disorder, we, just as bipolar 1, we need to make sure that it's not better attributed to something in the schizophrenia spectrum disorder family, okay? And the symptoms of depression or the unpredictability, this is what I was talking about, the overall experience, the unpredictability caused by the frequent alternation between periods of depression and hypomania. That's what causes clinically significant distress or impairment in one's social, occupational, or other important areas of functioning. Okay, so tying that together, again, I hope that that makes sense for you. Let's pause and reflect. Okay, what is the necessary symptom needed for a diagnosis of bipolar 2 disorder? And how many other diagnostic symptoms are required for the diagnosis? Think about what you remembered from bipolar 1. So we need to see persistently expansive, elevated, or irritable mood. Again, just as bipolar 1. And just as bipolar 1, we need to see 3 or more of the energy related symptoms. For elevated mood, plus 4 or more. Oh, I changed my tense. 4 or more for irritable mood only. Okay. Does a person's functioning need to be impaired while in a hypomanic episode? No. Although we do need to see a change in one's baseline functioning. It's the clinically significant impairment that comes from having been in a major depressive episode, from the overall distress caused by the shifting of polarities. That's what causes the overall impairment under the umbrella of bipolar 2. Does the person need to have met criteria for major depressive episode in order to meet criteria for bipolar 2 disorder? I hope by this time you're like, oh my gosh, Lindsay, get on with it. That's great. Yes, this is one of the key differences between bipolar 1 and 2. We know major depressive episodes are not required for 1, they are required for 2, although we can see them in both. All right, last one. How long must hypomanic symptoms persist in order to meet criteria for the diagnosis? The mood symptoms have to be present for at least 4 days. No stipulation about hospitalization, again, because we're not going to see that marked impairment that is needed to necessitate a hospitalization, and present throughout most of the day, nearly every day. Okay, so that's bipolar 1 versus bipolar 2. Here's the visual I was talking about. So, when we're talking about the DSM mood disorders, again, major depressive disorder, we can have a bunch of different presentations all under the guise of major depressive episodes, right? So, we can have a mild major depressive episode, moderate in severity, severe in severity, single, recurrent. They are all going to cause clinical impairment. That's what makes it a disorder. Now, bipolar disorder, bipolar 1, clinical impairment, because this is a manic episode. Now, bipolar 2, we can include, no, bipolar 2, we've got to see that major depressive episode, clinical impairment, yes. Hypomanic episode, clinical impairment, no. But yes, overall, as it relates to functional impairment because of this shift. You see my cursor? That's what I mean. I swear I'm not becoming hypomanic as I'm doing this. I promise you. So, to further build out this visual, let's go back to the graph from last week. Remember this that we did in class? Of course you did. Of course you do. Um, Here's one polarity. Now, in hypomanic and manic episodes, here are the dual polarities where here's the average mood. Again, this is the baseline. Think about hypomania. Again, if we've just experienced this, nothing else, we stay bipolar 2. What we can have is a person that after their hypomanic or manic episode, they go right down into a depressive episode. Does not always have to occur, but I'm just drawing this for effect. Um, and again, anytime that they go past the hypomania into the zone of mania, that's where we know it moves to bipolar 1. I'm going to show you what this actually can look like, okay? Forgive my all of my speech and the content on here, but this is what this can look like. It does not mean that this is what it looks like. It's not always that clean, but this is like in the mindset of somebody that is hypomanic and then manic. I'm feeling pretty freaking great. This is the elevated mood. Hey, I've got lots of ideas on a project to do. Can't stay focused on one task because I have so many great ideas. You know what? I'm pretty talented at a lot of things, and people really need to know this. So I'm just going to tell everyone. Yeah, you know what? I'm not needing as much sleep because I'm just so talented and I'm thinking about all the wonderful things that I'm going to do. And so I really only just get 4 hours of sleep last night, and I'm good. And then maybe the next night I'm going to get 2 hours of sleep, but I'm still good. You know what? I should probably call up my exes. Actually, my friend at work told me that's a bad idea. Well, maybe I need to settle down. And this could be the case of some sort of consequences. And let's just say that a person settles. It does not always happen in this particular way where somebody can will themselves to settle down. This might be medication. This might be some sort of extended period of time that the chemicals deplete and then they shift. This could be some other intervention, but let's just pretend that they settle. Now, this and they're somewhat around uh, the functioning of baseline of what we would normally see. Let's just say that they are experiencing increased stress, that they are not sleeping well for another reason. And this can happen where people's sleep, not because of excessive energy, can shift them into a hypomanic or manic episode. But let's just say that there's some sort of trigger, there's some sort of stimuli that gets introduced into their environment Then it's like, look who's feeling amazing again. Dang, I really am amazing. I should write 5 books about it. HarperCollins, what do they know they're missing out? I cannot believe that they skipped out on this fantastic author. You know what? I walked around downtown all day and night and no one wants to hear me sing, but I'm doing it anyways. I'm only getting 3 hours of sleep because I feel so amazing. Did you know that life itself is our most unreliable narrator? No one knows where it's coming or going or where it will be. Are we villains? Are we superheroes? Are we sent here as actors on the stage of life? Who is acting and who is not? What is the casting call? And for when are they going to give me my own show? Team No Sleep. I just gave all my money to my new friends that I made on the street. I even gave them my shoes. Oh, I got picked up by Pert. They're making me go impatient. I took my medication to make me sleep. I finally slept for the first time in 3 days. Not feeling as high as I was, but no one understands how great I am still. Still taking my medications and sleeping more. Oh, shoot, I just realized what damage I've caused over this episode. How did this happen? I swear, it seemed like I was doing the right things. And then this is where we can see somebody go into a depressive episode, whether that's following the manic episode, through chemical depletion, through shame and their behaviors while they're manic, as I was talking about. So, again, not a perfect picture as an example of this. Sometimes things shift, other times we need some sort of intervention to be able to cause this. In this case, if somebody is not sleeping, they are walking around downtown, giving away all of their money impulsively, giving away their shoes. They might very well get picked up. That might be because a family member knows that they're walking around downtown and they are not sleeping. They're not coming home. They're very concerned about them. They do a wellness check, and that's what happens. That's very possible. What we know is that medication is crucial in this experience of bipolar 1. And this is where I will talk about this on that slide. But okay, that's a snapshot to further build out your conceptualization. This is a busy slide, and I couldn't fit everything in here. So the title's way down at the bottom, the rule outs of bipolar 1 disorder. Okay, so again, we have to rule out major depressive disorder, right? Because it's just a matter of what's dominating the clinical picture. We have to make sure that when we are uh, even diagnosing for major depressive disorder, that we are asking about any sort of previous episodes of mania or hypermania. Okay. And so, what can favor bipolar 1 disorder as far as our clinical assessment is to ask about family history of mood disorders, to identify if there was an early onset in terms of adolescent, but there has been treatment and a person hasn't been in a hypomanic or, pardon me, a manic or hypomanic episode. Perhaps that the antidepressant can shift that person into mania. We just really we have to rule out psychosis, but this is where we're zooming out to make sure that we are covering all the bases to understand if this has solely been a unipolar experience or is this a bipolar experience. Now, we also have to rule out for bipolar 1 disorder, has there been a presence of just hypomania and not mania? Does it not meet criteria for either mania or hypomania, nor does it meet criteria for major depressive episodes, which I'll get to in terms of cyclothymic disorder? I talked about ADHD. ADHD can look like some presentations of hypomania or mania, especially distractibility, impulsivity, talkativeness, involvement in risky behaviors. Like that's what very much we don't really see so much of the sleep factor, but that can happen. The difference is that ADHD is a neurodevelopmental disorder. So we are going to see this before the age of 12. We're going to see this earlier on in childhood and to be persistent, more or less to be persistent in a person's life. Bipolar symptoms are going to be episodic. Thank God we don't see bipolar. Where we that would be awful for a person to be in a manic episode for years of their lives, right? Like that would just not work out effectively for their functioning and for just lots of areas of their life. But so that's the difference. Is it static or is it episodic? Okay. Now, we also know that we can see bipolar disorder that is occurring because it's substance or medication induced. And so, if a person is taking stimulants, I've often seen when I worked at the McDonald Center that people would be dually diagnosed, and so they would have bipolar disorder that was pre-existing, and then they would take stimulants because they loved being high. I didn't talk about this in the other previous slides. Well, I did mention this. The people feel good when they are manic or hypomanic. This is like a natural stimulant. And so I remember I had one of my patients that said, I used to love taking like either doing cocaine or a little bit of meth because I would want to be in a hypomanic or a manic episode. And then what I would do is I would use that to launch me into mania. And then I would continue to use in order to stay in mania. And so we have to distinguish whether there is pre-existing mania and the person, just like that patient, is using secondarily as a functional component to the mania versus, and with enough use, this can happen. Is the mania coming only because that person is using substances to begin with? Okay, so again, it's which came first, the chicken or the egg? Now, if mania is happening because of the use of antidepressants, then that's where we know that it can be diagnosed as bipolar 1 disorder. We also know, shifting to the next rule out, is that anxiety can really look like racing thoughts. This can look that avoidance can look impulsive, that people, well, this is where we get into a totally different experience in general of avoidance. But I would say that rumination can, in mimicking racing thoughts, can also cause sleep. Like we see sleep disturbances as a diagnostic symptom of generalized anxiety disorder. Um, I'm categorizing a lot of this PTSD actually is a trauma disorder, so it does not really belong in anxiety disorders, but can very much be characterized by a lot of anxiety. It's just a matter, again, of an episodic pattern or chronic symptoms, or like, again, what's static, or do we have evidence that there was an actual traumatic experience and that's where the symptoms began, or after that is where the symptoms began. So, um, we need to do a full assessment. I'm just laughing at my statement of there's a difference between, oh, I thought team no sleep. Yeah, there's a difference between team no sleep because of worry and team no sleep because of increased energy. I swear I'm not manic. Anyways, schizoaffective disorder. We'll talk about this in week 6, but psychosis can occur outside of mood episodes. This is where we have to, again, demonstrate due diligence in clinical tracking. If psychosis appears only during the mood episodes, that's where we can diagnose bipolar 1 with psychotic features. But if this is happening outside of that, that's where we can diagnose schizoaffective disorder. Again, more to come in that regard. We talked in week 4 about disruptive mood dysregulation disorder and how that was created to ensure that children were not getting overly or incorrectly diagnosed with bipolar 1 disorder or bipolar 2 disorder. So, this is where we're going to see chronic severe irritability as well as those anger and behavioral outbursts without distinct manic episodes. And so, this is where we're very much seeing a static behavior in disruptive mood dysregulation disorder versus these clear time limit, like sectioned episodes where there's a start, a middle, and an end. We do not see that in disruptive mood dysregulation disorders. Personality disorders, especially borderline personality disorder, that is a major rule out. This is so often and commonly misdiagnosed for women that they are diagnosed with bipolar disorder, where it might be borderline personality disorder, and vice versa. What we see, the commonalities are mood lability, impulsivity. We see a report of heightened anxiety. We see a report of difficulties in sleeping. We see reports of fluctuating moods. Some people, in my opinion, don't do a thorough enough assessment. And often the person that's reporting this of their own symptoms is not able to demarcate that fluctuation. Is that episodic or is that happening all the time? So with bipolar 1, this requires symptoms to represent a distinct episode or clear change from the baseline. With borderline personality disorder, this is a constant presentation. We will very much talk about this in our personality disorders week, but another conceptualization of this is that I'm sorry, oh my gosh. Um, this is where BPT is also confusing, that borderline personality disorder is a reaction, and the fluctuations in mood are largely seen as a reaction to what's happening in the environment, to stress, to relationship stressors. And so that's changing the mood, where the mood is fluctuating maybe for hours, that during the day you might see a shift in terms of irritability, sadness, more of an increase in terms of mood. But I would say somebody that is has a borderline personality disorder versus somebody that's manic, there's a marked difference between those two. When someone is manic. Again, that's where we go back to the dig fast mnemonic. That's where we go back to, we'll see this in John. That is not borderline personality disorder. So just know this as a foundation. We will continue to talk about this, but this is such a common misdiagnosis, one or the other. And so we have to make sure we're demonstrating due diligence to understand this is, I'll go back to a common thread. Is this episodic or stagnant or static? Pardon me. Is this episodic, or is this really happening throughout most of a person's life? If it's happening throughout most of a person's life, then it's probably not going to be bipolar 1 disorder. I hope that makes sense. Now, most common comorbidities of bipolar 1 disorder, anxiety disorders, I know that we want to rule them out, but they can also, per the DSM, they can also co-occur together. Alcohol use and substance use disorders, again, this is something that we want to rule out of what's induced, but to know that there's a functional use for some, whether that's coping or whether that's to stimulate entrance into a manic or hypermanic episode. But we also know that there's a comorbidity of ADHD. This is where it gets tricky. Don't worry too much about this. I'm just giving you a snapshot of this. There are other associations, that there are a group of people that are truly duly diagnosed with borderline personality disorder and bipolar disorder. It makes me so sad because both of these disorders are just so challenging individually, let alone experiencing them together. Oh my goodness. So just know that that exists. It is a very small percentage. Antisocial personality disorder can also be associated. Schizotypal personality disorder, again, um, another association, and untreated or just presence of medical comorbidities. My goodness, that's a mouthful. That can be the case where apparently there is a much, I'm going to read this from the DSM. I'm looking at page 150 of the DSM as I'm reading this. Individuals with bipolar 1 disorder also have high rates of serious co occurring and often untreated medical conditions, which largely explain the shortened life expectancy with those with bipolar disorder. Comorbidities in my goodness, I cannot read. Comorbidities appear in multiple organ systems with cardiovascular and autoimmune diseases, obstructive sleep apnea, metabolic syndrome, and migraine, more commonly among individuals with bipolar disorder than in the general populations. Comorbid overweight, obesity is a particular concern for individuals with bipolar disorder and is associated with poor treatment outcomes. I have like a third grade education in medicine just from working in a hospital over the past 5 years and working in critical care. What I would imagine, as far as the comorbidities of organ system issues, cardiovascular, autoimmune diseases, metabolic syndromes, migraines, it's almost like a car that's consistently revved up. Our cars are not designed to go 180 miles per hour for 6 hours on the freeway, right? Now, if a person is constantly revved up in a hypomanic or even more specifically, a manic episode. This is where the conceptualization comes from bipolar 1. If a person is revved up to that degree, I would imagine that would cause cardiovascular issues. Does that make sense? It makes sense to me. That if your body is constantly being stretched, and if we're looking at not getting sleep, right? To go for some people go for like a week at a time without a lot of sleep. And so that's taxing on the body as it is, depending on the emergence and the presence of how frequent an experience of manic symptoms are or manic episodes are, I could imagine that that really serves to cause or exacerbate medical issues. The other thing that I could imagine is if a person has, whether that's manic episodes or major depressive episodes, in most cases, while in these experiences, people are not taking care of themselves. If we look at the conceptualization of mania, I'm going to go back to this. If we look at the conceptualization of mania, that they are experiencing grandiosity, increasing goal directed activity, that's probably not to go to the doctor, right? Risky behaviors, they don't have a lot of insight about needing to take care of things. And I go back to the idea of grandiosity. If I think I'm going to live forever while I'm in a manic episode, or I'm thinking of actually some clinical cases historically that I've had where some people have religious themes to their mania and they perceive that they're here like to as a messenger from God or that things that are happening are coming from God. They're not thinking of taking care of their basic needs. So that's where I'm really reading between the lines of these comorbidities of medical issues and stipulating that that might be a good reason why. I'm very curious about this now. I want to go to work and ask some of my emergency medicine friends that I work with about this. So, more on that to come. But that's a new one as far as my conceptualization. Okay. I swear I'm not taking you on a total tangent where I'm bringing you back. Now, our next step is cyclothymic disorder. This is an interesting presentation. Okay, so we need to see this is basically mood and depression light. Okay, and when I say light, I mean like LITE. Okay, so for at least 2 years, and pull out this word, even though dysthymic disorder is an outdated word now, that's been replaced by persistent depressive disorder. But think about this again in terms of opposite polarities. So before we had dysthymic disorder, i.e., persistent depressive disorder, or that's what I meant, persistent depressive disorder, i.e., dysthymic disorder. I'm whispering because that's not the term that we're supposed to use anymore, but you're with me. On the other end of the spectrum, is cyclothymic disorder. So the conceptualization is the same that we need at least 2 years for adults, 1 year in children or adolescents, where there have been numerous periods with hypomanic symptoms ish that do not meet criteria for hypomanic episode, and numerous periods with depressive symptoms that do not meet criteria for a major depressive episode. We're not going to see manic symptoms on here because if that's the case, then we would identify or infer that at least hypomanic episodes have been present. So I will give you a visual in the next slide, but this is where it's close enough without going over or close enough without touching for 2 years. Okay, so during this 2 year period of episode, again, 1 year in children and adolescents, criterion A symptoms have been present for at least half of the time, and the individual has not been without the symptoms for more than 2 months at a time. Why do you think that stipulation is the way that it is? Just take a guess in your mind. We'll come back to this, okay? So we need to know that these symptoms have not been absent for more than 2 months at a time. Criteria for major depressive episode, criteria for major depressive, manic, or hypomanic episodes have never been met. The symptoms in criterion A are not better explained by the schizophrenia spectrum disorders. Okay. Again, we want to rule that out. That will make more sense in week 6. And again, we want to rule out any sort of substance use, medication use, or another medical condition. But the symptoms in cyclothymic disorder do cause clinically significant distress or impairment in social, occupational, or other areas of functioning. And we can specify if there's anxious distress. Okay, here's what cyclothymic disorder looks like. Okay, this is an EKG or an ECG readout of a good normal heart rate. This is like part of my third grade education, and I'm going to level up because this upcoming week in real life, this is, I'm recording this in July, not July, oh my goodness, January of 2026. I'm taking a 4-hour long EKG class to better understand this, but I took this from a snapshot on the internet. Okay, I swear I digress. This is what this can look like. So let's look at the graphs again. So a person's mood symptoms, I really love this because I think that this like fits perfectly. Mood symptoms are not quite meeting criteria for hypomania or major depressive episodes, okay? But we see that they are continuously, frequently occurring. So how do you think this would affect you? It would probably be tough, right? If you are overall not stabilized, you're not functioning within your normal baseline. This is different than exposure to stressors. It could be that we have stressors in our lives that cause us to experience dips and elevations in our mood, but most of the time, what we experience in our lives don't cause that consistent increase in energy, right? And that's, I think, always like a good way to be able to, to differentiate normal human life versus something that fits in the mood disorder category. Because once we start getting into that expansive, elevated mood that is not natural for most people, that's not within their baseline, and there's a shift in terms of energy, that's problematic. So, just like what we see in bipolar 2, it's not the hypomanic experience that is causing impairment, it's this overall zoomed out snapshot, okay? So the severity of the symptoms are low. This is basically where the sum of the symptoms is greater than its parts. I'm totally mixing up that expression, but I hope that that makes sense, right? The collective sum of these symptoms is greater in terms of functional impairment than the individual components of these mood shifts alone. All right, so we're going to pause and reflect. What's the necessary timeline for the presence of psychiatric symptoms to meet criteria for cyclothymic disorder? 2 years, 1 year for children. Oh, now what about the absence of symptoms? What's the extent of the period of time where there can be an absence of symptoms? No more than two consecutive months, right? So symptoms need to be present for more than half the time, but generally, that's what we want to think about, just like this. Do symptoms in cyclothymic disorder meet criteria for major depressive episodes, manic or hypomanic episodes? No, right? Because otherwise we would identify they would fit into the category of bipolar 1 or bipolar 2. And in individuals with this disorder, do we see stress and or impairment in functioning? Yes, because the overall experience of the rapidly shifting moods is what causes that distress. And that distress can cause a functional impairment. Okay, so for mood disorder specifiers, we have mixed features specifiers and rapid cycling specifier for bipolar 1 or bipolar 2. Mixed features. This is where essentially we have like a baby version of the, um, or a different kind of snapshot of what we saw on the EKG example. The best way to say this is that mixed features are a combination of both mood related episodes and depressive related episodes. So this can apply to, wait, how do I want to say this as far as breaking down all this information? So if a person has predominant bipolar disorder, but we also see that in the time of a manic episode or a hypomanic episode, that they are also experiencing 3 or more depressive symptoms during that episode, then we would identify mixed features. Conversely, if a person has major depressive disorder, I know this is goes against some of the diagnostic criteria, okay? But if they have major depressive disorder and we see these symptoms of elevated expansive mood, inflated self-esteem, more talkative than usual, flight of ideas. I'm just repeating just to continue to train you on this so you will pick up and remember these symptoms. I said flight of ideas, increase in energy, in goal-directed activity, increase in risky behaviors, and decreased need for sleep. And that's happening within the depressive period that we see 3 or more of these symptoms during that episode. That's where we would identify mixed features. Now, you might be thinking, well, wait a second. I thought that the biggest difference between major depressive disorder and bipolar 1 disorder and bipolar 2 disorder is that for major depressive disorder, we can't have any sort of presence of mania or hypomania. What's the difference here? That this is symptoms that actually are present in a depressive related episode, but don't actually meet criteria for time. Okay, so they're not happening independently from the depressive episode. They're happening within the depressive episode. This is very similar to the conceptualization of a depressive episode or a manic or hypomanic episode that has psychotic features embedded within that period of time, that they're only showing up within that polarity of time. Okay. And so this is where, in very small cases, we would identify mixed features. I think in all the years I've been practicing, in all the years that I've worked in intensive outpatient or inpatient psych, I've only seen this within like 1 or 2 people where it's like, oh my gosh, that's a mixed episode. These are mixed features. More often than not, we see a demarcation where somebody is in a distinct manic or hypomanic episode, or someone is in a distinct depressive episode, but we can identify the presence historically or later on of other episodes on the opposite polarity. This is a very special situation where we are seeing I guess I need to actually write this out too as far as the graph, but we are seeing in a block of time, whether this is um, I'm going to go back to manic. So 1 week with 3 or more of these symptoms, or 4 days with, oh, sorry, that's what I meant. 1 week with 3 or more of these symptoms, or 4 days with 3 or more of these symptoms. And I didn't say this, but the options that we have are the dysphoria or depressed mood, the anhedonia, psychomotor retardation, fatigue or loss of energy, feelings of worthlessness, excessive inappropriate guilt, or recurrent thoughts of death. We're not going to see the sleep factor in the same way. We're not going to see the appetite factor in the same way. And we are not going to see difficulties concentrating in the same way. Okay, because all of that, I think, better accounts for um, the features of mania or hypomania, where it's not that a person is sleeping not enough because they are bound by their depressive energy. It's because there's that defaults to a decreased need for sleep because of the excessive energy. I hope that that makes sense. Okay, but also, if we go back to a mixed episode within a depressive episode, we're going to see that within the 2 week period of time, we have 3 or more of these symptoms. Okay. So, again, if you have questions on this, let me know. I might at some point write out another graph to show you this, but I hope that that makes sense for now. So, that's the mixed feature specifier. Separately, rapid cycling specifier. This is where we have to see at least 4 mood episodes in the previous 12 months. So 4 and 12, okay? So 4 mood episodes within 1 year that meet criteria for manic, hypomanic, or major depressive episode in bipolar 1, okay? Or that meet criteria for manic, or pardon me, hypomanic or major depressive episodes in bipolar 2 disorder. We are not going to see 4 major depressive episodes in this period of time, because otherwise this is major depressive disorder. Okay, so the essential feature of rapid cycling bipolar disorder is the occurrence of at least 4 mood episodes during the previous 12 months. These episodes can occur in any combination and order. These episodes must meet both the duration and the symptom number of criteria for a major depressive, manic, or hypomanic episode and must be demarcated by either a period of full remission, back to baseline, or a switch to an episode of the opposite polarity. We need to see 4 distinct episodes. Manic and hypomanic episodes are counted as being on the same pole. Except for the fact that they occur more frequently, the episodes that occur in a rapid cycling pattern are no different from those occur in a non-rapid cycling pattern. Um, so, meaning that it's the episodes, the experience is no different. Yeah. It's just a matter of time. So you could have this shift. I'll show you this when I get to the next page, actually. Mood episodes that count toward defining a rapid cycling pattern exclude those episodes that are directly caused by a substance. Okay, so even though we might count that as a manic episode or a hypomanic episode, we are looking at independent, i.e., organic emergence demonstration. We're looking at an emergence of these disorders that's independent of a substance or medical condition. That's what I'm trying to say. So this is what this can look like, where we see that when a person has been in a manic episode, again, as a reaction to that depletion of chemicals, awareness, person can then go into a depressive episode. So 1, 2, they stabilize. This can really happen, actually. Stabilize, baseline, trigger goes on, they go into mania, medication, rest, stabilize for a couple months, and then they go back into a manic episode. This is a rapid cycling specifier, okay? And this causes distress for somebody. 3 manic episodes in 1 year, nobody wants that. Nobody desires that, okay? So again, I'm breaking this down. 4 mood episodes in the previous 12 months that meet criteria for manic, hypomanic, or major depressive episodes in bipolar 1, or meet criteria for hypomanic or major depressive episodes in bipolar 2. Episodes that are demarcated by either partial or full remissions of at least 2 months or a switch again to the opposite polarity. So here's my question for you as far as pause and reflect. Which disorder does this rapid cycling specifier belong to? Is this bipolar 1 or bipolar 2? Yay, bipolar 1, you said. That is correct, right? Because we have far surpassed hypomania. I guess that would have been a trickier question if I had like 2 hypomanic episodes and then a manic episode. But you know by now, if it touches the top, it's no longer in the realm of bipolar 2, it's bipolar 1. Now, a note on substance-induced mood episodes. So the relationship between substances and mania is unique and it's notable. Stimulants are known to trigger mania. Why? Do you know this? They're psychoactive, first of all, and they cause a person to not sleep. Stimulants are stimulating, therefore, people are known not to sleep while they're under the influence. That alone, not getting sleep, there's one thing that you really remember from this. That alone can really trigger hypomania or mania. So, this is where so much of treatment is about preventative measures. But stimulants essentially trigger the same type of reactivity in the brain as mania. And so that very stimulating euphoric effect can switch over and cause that independent hypomania or mania to occur. And I identified this before with you that stimulants are also used to maintain mania because, again, it keeps a person up. It keeps just so many of these symptoms overlap. Of what stimulants do is they cause grandiosity. Stimulants cause distractibility, flight of ideas, impulsivity, engaging in risky behaviors that have dire or really difficult consequences. That all is so similar. This is like these are best friends, unfortunately, like the most like toxic best friends, but like stimulants and bipolar disorder are very close and often create significant consequences for a person. Additionally, cannabis can trigger mania. This is psychoactive. This is sometimes how people learn that they actually have bipolar disorder, is because they smoke weed, they use some sort of cannabis product, and then they start to have racing thoughts. Then they start to really be working on this special project. They're starting to cure a disease that has never been cured or has always been cured. I don't know. That can trigger this. Lots of cases that I can think of that have experienced this. Cannabis, I'll talk about this in week 7. Cannabis is really tricky. As for something that is as common as it is, the risks in cannabis use are really high as far as triggering mood disorders and triggering psychotic disorders. So, because of how psychoactive it is, it can cause an increase in elevation of perception of an experience. Like it's really kind of on one end of the spectrum of uh, psychotics in the drug classes. And so, or yeah, I think that's the word I'm looking for. I'm in a different way of thinking. Um, either way, these are medications to, or these are substances to be really careful with, especially if you're treating somebody that you know they have bipolar disorder, or you know that they have even like a degree of a possibility of a psychotic disorder, a potential for psychotic disorder, a potential for mood disorder. To be using cannabis is to take on a significant risk. I know some people that hallucinogen, that's the word I was looking for when I said psychotic, hallucinogen. Um, and I know people that use cannabis to treat their symptoms of bipolar disorder. And to me, that's always like, no, 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 do not do this. Not only is this proven to not help your mood disorder, but it's proven to make it much, much worse, to trigger it, to prolong it, to make it more complicated, etc. And so, therefore, a period of mania, a hypomania, might actually be, going back to these questions, might actually be a substance induced episode, but we have to zoom out and look at the overall history of the mood presentation to truly determine if this is substance induced, or would it be coded as bipolar 1 disorder, most recent episode, manic as a primary, and then cannabis intoxication as secondary. Um, we just have to identify again which came first. That's that. I realize that it might be helpful to give you an example of coding bipolar severities. So, just as we've done before with regard to severities, we identify that we need to, well, we know that we need to identify whether bipolar options are mild, moderate, severe. I put in this case for bipolar 1 with the severities that mild designation would be minimal additional symptoms. Moderate would be a very significant an increase or in activity or impairment in judgment. And perhaps this is where it's like on the way to high level of care, but not yet there. Severe is where a higher level of care is medically necessary. So almost continual supervision is required to prevent further harm to self or others. Much more extreme, again, giving away things like walking down the freeway, getting in like a high pursuit car chase, like really significant stuff that you could hear about on the news. I'm not saying that every person that needs to go into the hospital is of that level, but think about it in that capacity, that the severity is like, hey, we are really concerned about your safety, or we're concerned that you are a danger to others without realizing it. And so that's where that severe designation would be warranted. So with bipolar disorders, what we need to also identify as far as severity is whether something is a single episode or recurrent. When something is recurrent, oh, pardon me. Regardless, so we need to identify the frequency of this, and then we designate the severity to it. Um, with something that's recurrent, what we get to do is identify the most recent episode. The most recent episode, is it manic or is it depressive symptoms? This is where we get manic depressive as far as that very old, much more antiquated term, right? Um, but so do we see major depressive symptoms or manic symptoms? Now, what we can also identify is, let's just say that you're treating them after their first episode, no significant events, mild. We don't need to specify most recent episode because that's the only one, right? So when it's recurrent, that's where we need to identify what the most recent episode is. If it's a single episode, that's where we can just leave that as it is. I didn't have this space in the first line to identify with or without psychotic symptoms, but let's just pretend that we can put that too. So in these options, bipolar 1 disorder, single episode, mild, without psychotic symptoms or without psychotic features, and then we could also do, did I miss? Oh, it's that technically is supposed to be 30.2, because that's for a single episode. Bipolar 1 disorder, single episode, severe with psychotic symptoms. I need to fix that. Sorry about the confusion. Okay, now let's review the graph. I'm going to give you a graph, and by sight, look at whether something is manic, hypomanic, timeline, etc. Tell me what this is. So we see our hallmark 2-week period of time. Obviously, this is not characteristic to what this can actually look like, but we're meeting the minimum criteria for bipolar 1 disorder. Now, if this was drawn to scale, does this meet criteria for something else? Yes, it does. What does it meet criteria for? I actually don't have this on here. Meets criteria for a rapid cycling specifier, right? Because we see 4 in a given year if this is actually drawn a scale. um, there, I fixed it. Okay, now how about this one? Same, but different, but same, right? 12 months tells us it's a rapid cycling specifier. That was easy. How about this guy? 2 years. What does that tell us? 2 years. No criteria is met. Cyclothymic disorder. How about this one? 4 days, 2 weeks. Bipolar 2 disorder. Yay! Okay, here's a mood disorder decision tree for further studying that you can use this if this is helpful for you. I'm not going to go into this, but just continuously breaking this down so you really, really get it. um, I have a breakdown for studying for you again. Just again, another way to be able to give you more information to help you with the disorder. And there's rule outs, which are very important. Breaking this down further from the DSM. Oh, hi, Kitty. Come here. My cat's hungry. Okay. Treatment options for bipolar disorder. What I'm going to talk about here is that so much of treatment, look, I've met with people who are hypomanic. I've met with people that are manic. I have seen videos. Last year, one of my students in supervision presented a video of meeting with a person in a crisis center, and that person was highly, highly manic. Do you think that she was able to do any sort of treatment with him? Heck no, right? This is like even trying to follow the line of conversation was impossible. Um, I'm kissing my cat. He's sitting on my lap. Mwah! Um, sorry. This is so funny. Anyways, therefore, we can do evidence-based treatment in helping people around their mood disorders. We would not do it when they are in that manic or hypomanic plane of the disorder. So this is really about how do we manage somebody's overall functioning? How do we work with them in the areas that we can to help stabilize them? But so much of what I think treatment of mood disorders comes down to is prevention. We need to educate our clients, our patients on medication management, on sobriety, if that's the case, on maintaining routine, on a sleep schedule, of taking care of their basic needs, because it's almost like the idea of, hey, you are at worst a ticking time bomb. And so if you're not sleeping, if you're not taking care of things, that can shift you into mania. If that's the case, if they have bipolar 1 disorder. And so you could be the best therapist in the world. You are not going to be able to help stabilize somebody when they are manic or at times hypomanic, or not even at times when they're hypomanic. And so that's where medications are going to be key. Now, I know that people have different perspectives on medication management. What's so important to identify is that it doesn't really matter what their beliefs are in that regard. If somebody, like I've seen videos, one of my patients at the McDonald's Center showed us a video on YouTube of him being in like a high speed car chase, and he was really, really very debilitatingly bipolar 1 disorder, and like just a great patient. We loved him so much, so charismatic, just such a good guy. But he would get in, every um, at least at worst a couple times a year. Further into his sobriety, it would happen occasionally, and it was often when he relapsed. But he would get into these really manic states where the video that he showed us was aerial footage from like a high-speed chase, and he kept driving his car literally until the wheels fell off. He was just on his rotors. He did not stop. Even though the police were trying to pull him over, he did not stop because he believed that God and angels were ushering him to safety. It wasn't the police that were after him, it was God. You could be the best therapist in the world and you are not going to change somebody's behavior like that, right? So this is where medications are key to mood regulation. And so this is why we call them mood stabilizers. So that goes back to what I said at the beginning. Mood disorders need mood stabilizers. Anti-seizure medication, antipsychotic medication, those can also be used as treatment for bipolar 1 or bipolar 2. Lithium is a lot less common in general now. That was the long-standing medication, just as a lot of psychotropic medications are now, where first order or first line, first class of medication, pardon me, first class of medication are often much heavier. When you hear people talk about, oh, I don't want to take that medication because I don't want to be a zombie, that's coming from a historical experience of lithium, not their experience, but that's like, these are stereotypes of medications of lithium. Next week, we'll talk about antipsychotic medications and Thorazine. That was like the classic hallmark zombie medication, because those are so heavy and they're really disruptive for a person. It's like they're numbing everything out. More commonly, when people are taking medications like Abilify, Lamictal, Depakote, these are really common first line medications that are given that can be so effective. As we go down the line in the cloud, that's where the medications get more and more heavy or severe. Most psychiatrists are going to start with these as entry points because they're really trying to stabilize a person first and foremost without being like drugging them. Alternative treatment, ECT can be very helpful, especially for getting a person out of very debilitating depressive episodes with catatonia, even manic episodes. Well, it's a little bit different, but depressive episodes with catatonia, when they go to that other polarity, that depending on the significance of the depressive components of the polarities, ECT can be so helpful for this. We have a lot of evidence that speaks to this. If you have questions on ECT, I'm happy to talk about this. But often they, again, really old, antiquated beliefs about medicine and how medicine was practiced in the 1950s. ECT is great treatment for severe depressive symptoms. Often the most common side effect is short-term memory loss. I'm not downplaying that. That can be pretty distressing to people, but it often goes away. It's just the first part of the few weeks where they're getting the ECT. but it's quick, it's really easy, it's not painful. Like I've seen it done before. We have ECT at Sharp Mesa Vista, and Dr. Marash, a really, really wonderful psychiatrist that we have there, invites clinicians to watch the procedure done. It's easy, it's quick, it's non-invasive. I think it is often it's really misunderstood and often underutilized, and can be a significant treatment form of treatment to help shift somebody out of these dual polarities. TMS can be used for the depression component of treatment. Psychedelics are not recommended because they're psychoactive. We do not want anything that's going to induce mania. So that's where we really stay away from this. Again, people use it. Alternative treatment, light therapy, regular exercise, sleep hygiene, building and maintaining routine. Again, we really want this for the treatment of manic episodes, but this alone is not going to be strong enough to get somebody off the ledge when they're manic. Okay, so just remember that. And goals for treating bipolar disorder. So, overall long term goal, symptom maintenance. Like, we really want stability in somebody's life. They do not want to go into these polarities of experiences of their episodes. And so, we want stability. Certainly, interpersonal and intrapersonal difficulties, like the toll that this disorder puts on oneself and others, the damage that it can cause when you start to treat people, whether that's regularly or infrequently, when you meet people that have bipolar 1 disorder, you're like, oh my gosh, I would not wish this on anybody. I say this for a lot of disorders. I say this for key disorders. I say this for schizophrenia. I say this for personality disorders, and I say this for bipolar 1 disorder. Does not mean that there aren't other disorders that are really, really impactful, but you meet where are you going? But, meeting with somebody, especially seeing them in a manic episode, you're like, "Oh my gosh, this is awful." So this is where we would really want to work on stability and impairment, because at a certain point, especially if we're talking about, co-occurring disorders with substance use disorders, family comes to not trust or to have a lot of burnout and fatigue by the impact of the ups and downs. And so reconnecting relationships is important. Going to short term goals, decrease crises and suicide risk. Again, remember, safety always goes first. Medication management, huge. Safety planning, what sort of level of care is indicated. How do we, if we're thinking about manic and hypomanic episodes being crisis, this is, which they really can be and are, this is where we were like, what point person can we have? If you're treating somebody in an individual setting and you know that they have a history of bipolar disorder, that's where I would want to identify, okay, look, we're going to do some safety planning, we're going to do some medication management planning, and also, you may not like this, but I really need to have somebody that you can give me uh, what's the word I'm looking for? That you can sign a release of information for, because I need to reach out. If you don't show up and I'm concerned that you are off in Vegas, I want to reach out to somebody to make sure that you're safe and see if they know where you are, right? So, like, I think we have the right to be able to do that. That's where we also want to work on decreasing isolation, increasing social support, increasing awareness of risk factors, engaging a person's social support family system is highly important. Also, identifying who in the family system or who in their lives relationally is a risk for either going into a manic episode, hypomanic episode, depressive episode, you get it. Mood stabilization. Again, that's where the symptom management is so important, right? What sort of psychoeducation does a person need? They might not know what triggers their episodes, that they really need help with that. They might very well need help with self-care, including sleep hygiene, making sure that they recognize what stimulates their brain unnecessarily, that they need to do digital detox at night before they go to sleep so that they are not continuously activating their brain. What sort of mindfulness techniques would be helpful? What sort of maladaptive thought patterns emerge from the presentation, contribute negatively to the presentation? etc. And then lastly, increasing emotional regulation skills for adaptive functioning. And so this is identifying what patterns of emotions or mood shifts happen. How do we identify what that looks like in terms of the things that one can do to regulate themselves as to not engage in or not perpetuate the intensity of episodes, identifying what automatic negative thoughts occur as a result of being in or having been in these types of episodes, what sort of distress tolerance skills need to be taught, how can a person engage in relaxation techniques, especially if they're stressed or distressed and we don't want them going into a manic episode, and then increasing awareness about episode warning signs. Then once you regulate this and stabilize this, then you can do other things. Let's just say the person's like, "Oh, I wanna deal with my relationship with my dad." It's like, "Well, we can't do that." Or my relationship with significant others. It's like, "Well, we really can't do that until you're stable, until we have a better understanding of how you can stabilize under the scope of your mood disorder." We might have to do relational stuff in the middle of this process, especially if that is making these symptoms worse. But that's where we have to look at what are the triggers and how do we continue to really stabilize a person. All right, lastly, your homework assignment for this upcoming week is to submit the I Can Start To assignment for Iris. And that is going to be applying your skill set, what we've talked about in the lecture and what we've talked about in class, to this vignette. The reading and preparation for week 6 is from the DSM, from CREST Chapter 10, and you're going to be reviewing the Handbook of Differential Diagnosis. As always, please reach out to me, email me with any questions, whether that's in response to the lecture or in preparation for class. Thanks, everybody. Bye bye.